Hello and welcome to another intensive care hotline and intensive care at home emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I'm your host, and I've been doing these YouTube live streams for quite some time, usually once a week here at intensivecarehotline.com and intensivecareathome.com. Now, if you want to support our work with Intensive Care Hotline and Intensive Care at Home, give this video a like, share it with your friends and families, and comment, your thoughts, any questions you have. That is always welcome. Now, before we go into today's questions, what makes me qualified to host an emergency Q&A for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background, and I have been working in critical care and intensive care for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and where I've been consulting and advocating for families in intensive care all around the world since 2013 here at intensivecarehotline.com. And I can confidently say that we have saved many lives with our consulting and advocacy at intensivecarehotline.com. And you can verify that on our testimonial section at intensivecarehotline.com, and you can also verify it on our intensivecarehotline.com podcast section. And we have done client interviews there to verify the work that we've done. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending intensive care nurses into the home 24 hours a day for predominantly long-term ventilated adults and children with tracheostomies. We are currently operating all around Australia with Intensive Care at Home, but we can also help you privately in the US and in the UK if you are interested there. You can find more information at intensivecareathome.com. Now, without further ado, if you have any questions that you want to have answered today, just type them into the chat pad or join me live on the StreamYard link here. I'll put the link in the chat pad. Feel free to type in your questions or join me live on the StreamYard link and talk to me directly. Now, I also want to welcome the viewers on replay. I know we're getting quite a few views on replay during the week, so I want to welcome you as well. Let's get to the first question. It's actually not a question today. I actually want to read out a letter or an email that we've written to an ICU to successfully advocate for our client to stay in ICU instead of going to LTAC. Obviously, this is for one of our clients in the US. And, I'll just read out the email that we've written on our client's behalf. And you can see, and you can use it verbatim for your family member if you want to stop your family member going from ICU to LTAC if you're in the US. But even if you're not in the US, you will learn a lot just by me reading out the letter. So this is a letter, an email we crafted to hospital executive for one of our clients. And by the way, we've helped hundreds of clients and members over the years when they have a loved one in intensive care to get results, right? You just need to question things, which is very important. Okay, so let's read out the email. I'm writing you in regards to my family member. I'm obviously not going to mention names here. Currently an inpatient in your ICU. First off, we've been very grateful for all the care my mother has been receiving in your ICU to date. We have been very happy with the progress she has made to date, thanks to your excellent care and expertise. After she was readmitted from LTAC, just as we predicted before her prior discharge from ICU. In fact, the admittance report from ICU said she was admitted from LTAC in dwindling condition with sepsis and acute kidney injury. As a matter of fact, she was shaking for several days before the transfer. It looks like it was a sepsis or a septic shock. It is, however, deeply concerning that ICU wants to discharge my family member again to an LTAC once again without our wishes and without our consultation, let alone our consent. We strongly fear that the level of care in LTAC is not appropriate for the clinical condition of my family member, as we believe my family member still needs ICU level of care. And I should interject that it's not even only a belief, it's us reviewing medical records and gathering the evidence. But I will come to that, to the evidence in a minute. So it's not only, saying we think that LTAC is inappropriate, it's about having the evidence, and that's where our medical record reviews come in. So then the email continues. The clinical evidence that my family member is not ready for discharge to LTAC is overwhelming. Specifically, my family member's atrial fibrillation appears to be chronic now, and in combination with a pericardial effusion, my family member needs to be reviewed by a cardiologist before being discharged from the ICU. Presently, my family member also has a lung infection and Acinetobacter pneumonia. My family member has been vomiting and is nauseous continuously. They just started my family member with a course of strong antibiotic meropenem last week. Furthermore, my family member's hemoglobin level is still concerningly low at a level of 6.6. And we know after speaking to other ICU professionals that LTACs, generally speaking, do not have the specialists available dealing with significant cardiac or hematology issues such as atrial fibrillation, pericardial effusion, and low hemoglobin. Blood transfusions are, generally speaking, not an option at many LTACs, and the patient must be transferred to a local ICU again. When we were at LTAC, one of the RNs also said that if a patient was needing frequent blood transfusions, like my family member is, they would send them back to the ICU to find out what the cause of the blood loss was. Currently, this is the frequent blood transfusion history. Since the 25th of February, 7 days since last transfusion. 18th of February, 5 days since the last blood transfusion. 13th of February, 4 days since the last blood transfusions, and the 9th of February, second day for the last blood transfusion. So, you got to look for the patterns. But the problem is, 99.9% of families in intensive care don't question. They do not question, and that's why they get walked all over. Okay, the email continues. Moreover, my family member is now on intermittent dialysis and therefore is way more clinically unstable compared to the last ICU discharge. My family member is now hemodynamically unstable with vasopressor support, i.e. midodrine, to manage hemodynamic instability that inevitably often goes hand in hand with vulnerable patients on hemodialysis. The nursing skills in an LTAC don't allow for the management of hemodynamic instability, let alone the management of vasopressors safely. And before I continue with the email, we've done our research. There are no ICU nurses in LTAC, right? And you can't manage hemodynamic instability, let alone the management of vasopressors, without ICU nurses. That is an intensive care and critical care nursing skill, full stop. There's nothing to add there. The email continues. It's also evident, despite the rhetoric, that LTACs get very poor outcomes for patients when it comes to ventilation and tracheostomy weaning. Clearly, LTACs often work with lowly skilled and non-specialized nurses that have no ICU experience, which is needed to manage ventilation and tracheostomy. Weaning off the ventilator while in ICU would open up many rehab opportunities for my family member. On the previous LTAC admission, my family member had made no progress in terms of ventilation weaning. This is often what we see, right? We've seen so many times that ICUs promise or say to families in intensive care in the US, or your loved one needs to go to LTAC because LTACs are specialized on weaning, on ventilation weaning. Well, nothing could be further from the truth. Nothing could be further from the truth. We have So many desperate families in LTAC reaching out to us, begging us to help them to go back to ICU because they realize the ICU has been lying to them, has been absolutely untruthful, telling them, oh yeah, you go to LTAC and then the ventilation side and the weaning side of things will be taken care of. And then families realize they've gone from bad to worse, right? Then to continue with the emails, the nurse-to-patient ratio in an LTAC, as well as the lack of ventilation and tracheostomy competent nursing staff, is not appropriate for someone on a ventilator with a tracheostomy. There are no specialist doctors on site 24/7, which is not appropriate for someone on a ventilator with a tracheostomy, supposedly being weaned with multiple comorbidities just coming out of ICU, right? The definition of insanity is to do the same thing over and over again, expecting a different result. In this case, I mean, like going to LTAC over and over again sounds like insanity, right? Because patients bounce back to ICU all the time, or worse, they're not making any progress, then they'll be discharged to a skilled nursing facility, which is even worse than an LTAC. So the email to the hospital continues. Therefore, the clinical evidence that my family member is not ready for discharge to LTAC is overwhelming. We perceive discharge to an LTAC facility as medical negligence, and we will not hesitate to mobilize our legal team to challenge any real or perceived medical negligence. I have repeatedly asked for the hospital discharge policy and have encountered nothing but excuses and have not seen such a policy. And what that means is, here's what that means. If the hospital is not happy or not willing to share the hospital discharge policy with you, that's a sign that the hospital discharge policy is saying something along the lines of they can't discharge your family member without your family member's consent or without your consent. That's what it basically means. Otherwise, they would show you the hospital discharge policy. Rest assured in there. Make no mistake. So the email continues. We strongly object to a discharge to an LTAC with poor online reviews. Look up the online reviews of LTACs. Strongly recommend that you look up the online reviews of LTACs. To be an eye-opener for you. It appears to border on insanity to send my family member to an LTAC in their extremely vulnerable condition while being at high risk of being readmitted back to ICU due to their medical complexities. This is exactly what happened in early February, just as we predicted at the time. Surely to repeat the same happening again can't be in the best interest of my family member. If my family member was to be readmitted to ICU, they would most likely be readmitted to another ICU due to the location of the LTAC. That means my family member would potentially be in 4 facilities within a short period of time. This is anything but holistic care, and it completely ignores the individual and our family. If such events would occur, we would most likely perceive it as medical negligence also. Patients who are as vulnerable as my family member need stable, multidisciplinary teams around them rather than being sent off to substandard LTACs where a new team has to get to know my family member from scratch. This makes no sense whatsoever. As a next step, we request that a cardiology and hematology review is to take place as a matter of urgency, and we object a discharge to the LTAC. Right? And this is often enough to stop them from doing it, right? And you can use it verbatim if you replay it. You know, of course, there will be the clinical details that are unique to your family member, right? But that's where we can help you with to break it all down and make the advocacy case. You know, that's what we do. And that's what we also do best, right? By breaking things down for you. Now, here's another thing. In the next few days, I will launch a podcast with one of our clients that I've just interviewed yesterday. We're just in the process of transcribing the podcast and getting it edited and all the rest of it. But Case in point. So there's a client that we've worked with for quite some time now, and they had their family member in ICU last year. It was a very similar situation where ICU wanted to discharge her to an LTAC. No, I need to go one step back. ICU actually wanted to withdraw treatment, right? And our client obviously objected with our help, successfully objected with our help. Then the next thing they wanted to do is they wanted to send her to LTAC. Again, the client successfully objected with our help, right? Next, the ICU wanted to play the game of, oh, your family member is running out of ICU entitlements. That's what the insurance says. And the ICU was blatantly lying to them, because we asked the client to check in with the health insurance. And when they checked in with the health insurance said, no, she's got plenty of entitlements for ICU days as long as the clinical condition warrants an ICU stay, which it did. So lo and behold, with all of our help, with all of our advocacy, but also with a lot of legwork from our client, their family member stayed in ICU, got weaned off the ventilator, and then eventually went home. What ICUs in the US will often say is, oh, they're not specialized on weaning patients off the ventilator. Well, if ICUs are not specialized, who is? Definitely not an LTAC. Definitely not an LTAC. Right? I mean, again, I've worked in critical care and ICU for nearly 25 years. That's what ICUs do. They just don't want to, if they don't have to. It's the one-stop shop to send patients to LTAC in the US. It's out of sight, out of mind. But it's not holistic. It's not patient and family friendly. And you gotta think on your feet. You have to think on your feet. And you have to do your own research, and you also have to take responsibility for outcomes. Right? If you're not taking responsibility for outcomes, you're not getting very far. You're not getting very far. Right? Okay, so I can see there's quite a few people here. Please type your questions into the chat pad, or send your or join me live on the StreamYard link. Right? Either or. I also have done another YouTube live a few months ago with the title 10 Reasons Why LTACs in the US Are a Scam. And I'm not making an apology for the title or for the video, because it's just my observation. It's just, my research has shown that they are a scam. Right? Unfortunately. Big scam. If anyone wants to make a comment about LTACs here, feel free to make a comment, or again, join me live on the StreamYard link. Now, here is another letter from another client that we've written. Again, you can use that as is. Where is it? Why can't I find this now? Okay. So here's another email from a client who says, "Hi, Patrick. I spoke to the nurse, and the nurse said the transfusion of blood, platelets, and all clotting factors are okay, but he said no to fresh frozen plasma. That is not bleeding, because the bleeding is not that bad anymore. Also, I told the nurse to let the doctor know we need to know the cause of worsening patchy opacities throughout the bilateral lungs needs to be ruled out and determined, so appropriate treatments. I spoke to the doctor earlier in the day, and they said my mother's liver is slowly shutting down and that they're giving her lactulose and rifaximin, but we'll check the ammonia levels tomorrow. And I have told the nurse and the doctor about following up with a nephrologist for high creatinine, hemodialysis, etc. The nurse says they are sure the doctors are aware of it And the ICU doctor says because her liver is not functioning right, because of the liver cirrhosis, it's affecting her kidneys, and that's why the kidney levels are so high, and they're doing whatever they can. But they think she may only have a week or so to live because of her cirrhosis. But I told the doctor to follow up with a nephrologist for the high creatinine. I will be at the hospital tomorrow to visit my mother. If you have any questions or concerns you think I need to ask or tell the doctor tomorrow, please let me know so I can address them. So whenever there's blood transfusions to be given for patients in ICU, especially when there's a lot of bleeding going on, right? One way to stop the bleeding is obviously to stop all anticoagulation, such as warfarin, heparin, clexane. That's one way to deal with excess bleeding, right? But there could also be low platelet count, right? And if there's low platelet count that causes bleeding, then a platelet transfusion needs to be given. Or if the clotting factors are off, such as INR in particular, then fresh frozen plasma can be given, right? That's also a blood transfusions. Now, and this is obviously, this is an email from Russell, and Russell also wants to know the cause of worsening patchy opacities throughout bilateral lungs. So here's what that often means. It means that patients, despite mechanical ventilation, their lungs are not well perfused. And that could be an issue around patients lying in bed all day, patients not being mobilized, right? Maybe incorrect ventilator settings, patients potentially not getting enough physiotherapy, patients not sitting up so that the lungs can actually expand, right? Or patients could be too drowsy. Russell is talking about his mum's ammonium levels being too high. Now, when ammonium levels are high, it can often be a sign of liver failure, which is the case in Russell's mum's situation, right? So, also he says, that they say his mum may only have a week to live. Now, I find this very interesting because these are emails from a few weeks ago. This is a client we worked with, and his mum is still alive to this point, right? So you really have to question everything. And you have to question, why are ICUs creating this narrative of, patients needing to die? What's the rush? What is the rush to kill a patient in ICU? You always have to wonder that. Where's the urgency to kill someone? Isn't that horrible that ICUs are in a hurry to kill patients, right? Why is that? I would welcome your views here. I have my own views, and I think that it's population control. I think it's pressure, pressure for families in intensive care to make them think they have no rights, right? To make them think that ICUs are in control about life or death, right? That's very scary, actually. It's very scary, actually, and we have to fight this. We have to fight this. But I can't do it all by myself. I need your help. I need your help to speak up. I need your help to speak up. We can't let this go by and let ICUs run rampant and let them do whatever they want. Now, disclaimer, I'm well aware there's a lot of good things happening in ICU. A lot of patients get treatment and they get out well, and they get on with life, and that's a fantastic thing. But the reality is that people who stick around here, for them, things don't go straight forward, right? And if things don't go straight forward, all hell might be breaking loose. All hell might be breaking loose, right? So, let's get on to the next email, and please type your questions into the chat pad. type your questions into the chat pad or join me live on the StreamYard link if you have any questions. So now here's another email that we've written to hospital executive for one of our clients. And again, I'm not going to mention names. Dear Mr. So-and-so, I hope this email finds you well. I would like to provide you with a comprehensive update regarding the ongoing issues and instances of discrimination experienced by my family and the patient, my mother, ranging from the medical staff to the administration at the regional medical center. Despite the determination made by the ethics committee, which concluded that ongoing active care would be beneficial based on the patient's clinical scenario, persistent challenges and the family's expressed desire to continue with such care, we have observed minimal improvement in the patient's health and clinical condition. This can be attributed to the lack of implementation of essential medical practices and insufficient attention given to the patient's needs. Regrettably, we have not received any communication or acknowledgement from your esteemed administration concerning these pressing matters. The problems we initially highlighted, along with the urgent need for resolution, remain unaddressed, leaving us deeply concerned about the lack of accountability and continued discriminatory practices that persist at the highest levels within the organization. Despite the medical staff awareness of the patient's need for assistance, the situation has not improved, resulting in additional challenges for the patient and my family. I would also like to draw your attention to the unresolved issue related to medical records. Despite the initially promised timeline for resolution, which has now exceeded 1 month, there has been no progress or resolution in sight. Unfortunately, the director and administration have resorted to deflecting responsibility by engaging in a blame game rather than demonstrating effective leadership and taking proactive measures to rectify the situation. Despite our prior communication clarifying that the third-party service is not at fault, the focus remains misplaced, attributing blame to external entities. The crux of the matter lies in the excessive file size and incompatible format employed by the regional hospital when uploading patient records, resulting in significant impediments to efficient data management. Urgent attention is required here to rectify this issue promptly. The trusted third-party service provider, My Health One, has diligently endeavored to troubleshoot their system and develop potential solutions for accessing the medical records, but the regional medical center has yet to take substantive action to address their ongoing data-related challenges. Consequently, the patient's file remains excessively large due to data upload issues, underscoring the pressing need for resolution. It is disconcerting that a seemingly straightforward matter such as data management has not been promptly addressed, particularly considering the abundant data solutions available in our current digital era. This lack of accountability and effective leadership within the hospital is deeply concerning. As we approach the point of exhaustion in our efforts to reach a satisfactory resolution for the numerous challenges faced during the patient's tenure at the regional hospital, it is disheartening to note that our concerns have been met with disregard and insufficient follow-up. Therefore, we feel compelled to escalate our grievances and concerns to the Medical Board of California, as it is vital to apprise them of the extensive details regarding the challenges we have encountered and the inadequate responses received thus far. Thank you for your attention in this matter. We sincerely hope that swift and appropriate action will be taken to address and resolve these ongoing issues, thereby ensuring the delivery of compassionate and holistic and high quality care. Again, you can use this for your own good. You can just, replay it if you like. And then after that, the client got access to the medical records, right? Again, we are getting results for our clients, which is really important for you to note. Now, I'd be curious to know if anyone on this call had some has some similar experience that they want to share here, or if you want me just to continue to read out the emails that have come in during the week. Yeah, I'd be curious to hear what you have to say here. So then, here's another email that we sent or wrote on behalf of our client to hospital executive. Dear Mr. So-and-so, I trust this email finds you in good health and high spirits. I would like to take this opportunity to update you on the recent developments. Firstly, I would like to inform you that I'm not going to mention hospital name now. No, this is actually, I would like to inform you that a hospital CEO has apprised me of the situation and assured me that the matter has been duly escalated for immediate attention. The purpose of this email is to communicate our disappointment and concern regarding the ongoing issues of discrimination and inadequate treatment that persists between our medical staff and the administration at the regional medical center. Despite the verdict of the ethics committee, which determined that ongoing active care is crucial based on the patient's clinical scenario, persistent issues, and the family's expressed desire to continue such care, we have yet to witness any notable improvement in the patient's health and clinical condition. Regrettably, the absence of essential medical practices and the lack of proactive intervention have contributed to this unfavorable outcome. This is actually the same email that I read out earlier. I do apologize. I need to go back to another email. My apologies. All right, so let's keep it moving. Let's get on to the next question. Here it is. Question is from Arxi, who says, "Hi Patrick, I'm grateful to read your videos, but I know recently from experience there's no coming back from sepsis and pneumonia because I lost a loved one in intensive care from sepsis and pneumonia." Well, Arxis, what I have to say about this is maybe you didn't have the right advice, right? I'm sure the intensive care team made you want to believe there is no returning back. And once they've planted that narrative in your seed, you probably believed it, right? One thing that families in intensive care have in common that get results and get outcomes is they take full responsibility for outcomes. What that means is they seek advice, right? They seek a second opinion and they do their research. I mean, one of the things that I've been saying here for many years is that, number one, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care, which is exactly what you are dealing with here, right? And because you don't know what you don't know, you just get on with the narrative that's being presented to you. Now, if you get on with the narrative that's being presented to you, it means you do what 99.9% of families in intensive care do. They don't question, but you have to question. You have to question everything, right? And the reality is that 90% of patients in intensive care approximately survive. 90% of patients in intensive care survive. So why should your family member not survive? Tell me why. Give me a reason. Why should your family member be 1 out of 10 not surviving? Have you done the research? Was it a real or was it a perceived end-of-life situation? Right? I tell you the difference, and I've made countless of videos about this over the years, the difference between a real and perceived end-of-life situation. So a real end-of-life situation is that no treatment, no surgery, no medication, no equipment, no nothing will save your loved one's life. They're going to die, full stop. That's a real end-of-life situation. A perceived end-of-life situation is when ICUs create this narrative of, oh, you know, your loved one's going to die. and there's nothing we can do, and it's in their best interest to die, we should just move them to hospice. That's a perceived end-of-life situation. There's a perception, no more than that. And that perception could become a reality if you let it. Well, the crux of the matter is here to not let it become a reality. That's the crux of the matter, right? It's up to you whether you let it become a reality or not. It's about taking full responsibility. I mentioned earlier that I recorded a podcast yesterday with one of our clients. Now that I refresh my memory, here's what she said, and I remember that at the time when we were working with her one-on-one. She said one of the palliative care doctors said to her, "Oh, we can take care of your mum dying tonight." Can you believe that? They said, "We can take care of your mum dying tonight." What does that sound like? Does that sound like they want to save lives? Or does that sound like they're in a hurry to end lives? And what does that mean if we're actively ending lives? What does that mean? What does that mean for society? What does that mean for the medical profession? What does that mean for the nursing profession? I welcome your comments, but I welcome your comments. What do you think? What do you think? What message does that send? What message does that send? All right, so let's get on to the next question from, it says Need Bear actually. Hi Patrick, my partner had a cardiac arrest a week and a half ago and he's in ICU. He had a tracheostomy and he's hopefully coming off fentanyl and sedation, but he's very restless, and although he responds to requests, I feel like I can't help him to calm and not try to pull at his tubes. I'm hoping it improves as he comes more out of sedation, but it is very hard to watch him look so uncomfortable. Is there something I can do other than talking to him? So, like I say, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what you're up against here, Need Bear, because you just don't know what you don't know, right? So, first off, if he had a tracheostomy, he should no longer be on sedation. He should no longer be on fentanyl or any other opiates. When you look at the literature, when you look at the research, one of the goals of a tracheostomy is to eliminate sedation completely, to eliminate opiates completely, right? That's one of the main goals of a tracheostomy, assuming someone can't be weaned off the ventilator, right? So you have to question their approach. What's the delay in your partner waking up? Also, he's responding to requests. That's really, really good. But the question remains, has he had a CT scan of the brain or an MRI scan of the brain? In terms of calming him down, I would absolutely say you should be talking to him 100%. Right? I would also say that, getting very good nursing care, which means, regular washers, even a shower, which is possible for someone with a tracheostomy. Don't let anyone convince you otherwise, right? Time and very good nursing care and, best medical care and treatment is the ultimate healer, but also so that he's not getting deconditioned, he needs to have physical therapy, he needs to be able to get mobilized and all the rest of it, right? So, very important here. But once again, I can't stress enough that the reason for a tracheostomy is to stop sedation and opiates. So what are they doing to continue sedation and opiates? No need for that. Absolutely no need for that. If anything, I'd say it's negligent. Right? So you have to question everything. And you can't just take what they say for gospel. You always need a second opinion. Always, always, always. Right? Now, let's move on to the next question. And I welcome your questions here as well. I know if you have any questions or you want to talk to me live on the show here, please do so. Join me live on the StreamYard link or type your questions here directly. Now, another thing that I want to highlight quickly today is, so here's a link to the StreamYard link again if you want to talk to me directly. Another thing that I want to talk about today is spontaneous breathing trials versus gradual weaning off the ventilator. So here's why I want to bring this up. We are currently working with a client who has their loved one in ICU, ventilated with a breathing tube for about 2 weeks. And the ICU was trying to do spontaneous breathing trials without weaning the support from the ventilator down gradually. Lo and behold, the client failed spontaneous breathing trials over and over again, with ICU saying, oh, he's not ready for extubation. And when we looked at the medical records and when we looked at what was happening in much detail, we realized, well, they're basically putting him from a controlled ventilation mode where the ventilator is doing all the work to a spontaneous ventilation mode. And he was failing the spontaneous breathing trials, and no surprises. You know, in the medical world, it's called sort of the quote-unquote sprinting process, but rarely have I seen it work. It might work for young patients where, they probably shouldn't have been intubated in the first place. That's where this might work. But I haven't seen it work in an elderly or frail population, which is where this client's category is in. Right? So, what needs to happen is a gradual weaning needs to take place, not a sprinting, in almost any case. So if you're wondering, how should weaning off the ventilator and the breathing tube proceed? And the same, if someone is on a tracheostomy, it should always be a gradual process, not a sprinting process. It's a bit like, if you want to run a marathon, you must train for it. You can't just run a marathon without any training, right? Common sense. I can only encourage you, always bring it back to common sense. Always, always, always. If you're in doubt, just think whether it's common sense, and whether it would make sense with anybody else you'd be talking to. Right? So that covers that. I have another email here from Marianne who says, hi, Patrick. Our parent is in ICU for 4 days now, and he's just had a tracheostomy. I have observed that the nurses in ICU were not suctioning the tracheostomy like liquid is seen to spill. Is this all right? I have observed that the nurses in ICU were not suctioning the tracheostomy like liquid is seen to spill. Is this all right? I don't quite understand your question, but what I will tell you is this. So when someone is having a suction through a tracheostomy, a suction catheter needs to be used, and like liquid is seen to spill. I think I know what you mean now. You probably mean that they're not putting in saline for a bronchial lavage. I think that's what you're talking about. Yes. So some suction practices, mainly previous ones, older ones, have shown that you can put some saline, normal saline, down the tracheostomy tube or down the breathing tube to loosen up secretions, right? And that was common practice when I first started out in ICU in the early 2000s, right? However, most ICUs have moved away from that. Why have they moved away from it? Simply because patients have reported that they feel like drowning, right? They feel like drowning, which is a horrible feeling. And it also means that patients might come out of ICU with more post-traumatic stress. And you don't want that. It's traumatic already as we speak. You don't want patients to come out with post-traumatic stress. So, there are some ICUs where it's still common practice. We have some home care clients with intensive care at home where we still do it. However, this is the client's request at the client's request, right? And if they want it and they feel like their situation is improving with putting saline down the tracheostomy or the breathing tube for patients in ICU, then so be it. But most ICUs have gone away from it nowadays. So I hope that answers your questions or question. Then let's move on to the next question. Or if you have any questions, please type them into the chat pad or join me live on the StreamYard link. Usually I go for about an hour, so we've got another sort of good 12 minutes or so. Please join me live and talk to me directly here. If not, I'll just carry on with the emails that have come in. And here's another email from Aaron, who says, "Hi Patrick, my parent got written off so fast they wanted to send them home, but there's the catch. They get no treatment at home besides the oxygen they give you. Fight it until the very end. They can still be in hospital receiving care such as antibiotics and fluids. They don't need to be on a machine and a coma. Please, please, everyone, for the sake of loved ones, fight it out until the very end and get the treatment." Look, that's what I've been saying for a long time. I'm lacking context here with your email, but you're absolutely right. Unless there's an advanced care directive from either patients, families, that they don't want everything done, I argue everything should be done. We've been advocating for this for a long time because sometimes situations can be turned around. And there's plenty of time to talk about end of life. If things don't work out, there's plenty of time to talk about end of life if things don't work out. The reality is that if you give in to end of life from day one, you know the outcome, right? You know the outcome. If you don't give in to end of life from day one, well, you give your loved one a chance. Which one do you want? Which one do you want? Do you want to give your loved one a chance or not give a chance? It's very simple. It is very, very simple which one I would choose. So let's move on to the next question. And if you have any questions, type them into the chat pad or join me live on the StreamYard link here. So here is another email from Mark. This is in response to a video that I've done, and the video that I've done was the title of "My mom's on ECMO after open heart surgery, now kidney failure, heart failure, and fluid overload, help." And this is in response to that video where Mark says, "This happened to me at Emory Hospital in Atlanta, Georgia after heart surgery. My heart failed, my lungs failed, my kidneys failed, and I had to be put on ECMO. I was on ECMO for 2 weeks, 20% chance to live, but thank God I had a lot of people praying for me, and I'm here today. That was 4 years ago. There's always hope. Never, ever give up." Well, again, just ties right in with what I said a minute ago, that, you know, you should never, ever give up. You know, because if you give up, you know the outcome. If you don't give up, you don't know the outcome, but you've got a fighting chance. You know, you've got a fighting chance. So, next question, a chance to continue life. That's exactly right, Helene. That's exactly right. You know, it's, you just don't know. But you do know if you end someone's life. That's for sure. Now, here is another email from Joseph, who says, my dad's been too long on a breathing tube and in an induced coma. Now, that is a very general statement. It's very general, and it again, it shows me that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. What does it mean if someone is too long on a breathing tube and in an induced coma? You know, what does that mean? Why is your family member in an induced coma? Why are they on a breathing tube? Maybe it is the right thing to do to keep them on the breathing tube and the induced coma. It really depends on the situation, right? Whilst it probably feels like an eternity for you, the question is why. You know, the question is why. You know, that's why you need a second opinion. That's why you need someone to look at the medical records. That's why you need someone to talk to you and your family directly. That's why you need someone to talk to the doctors and nurses directly. Right? But I also understand that most families in intensive care feel completely lost. They don't know where to start. I get it. I totally get it. You know, I totally understand how you feel. You know, you're not getting the answers. You don't know where to start. You know, when working in intensive care, it's like it takes years of study, it takes years of practice to become proficient in it. You know, that's why I feel comfortable, you know, doing a Q&A. You know, and I understand that it's completely overwhelming for families in intensive care to look at their loved ones and not knowing what to do next, not knowing what questions to ask. You know, okay, let's move on to the next question. And the next question here is, well, their name is Sin City Outdoors. It says, hi Patrick, thank you for your videos. My family member had a heart attack and his wife woke up in the middle of the night with him struggling to breathe. She thought he was having a nightmare and tried to wake him for a minute or so and then called 911. They told her to start CPR immediately. He started to turn blue when she started. The paramedics were there within 11 minutes of her doing CPR. Here we are at day 4 with all his organs doing fine, but waiting on an MRI of the brain. Your videos give me hope. I'm not sure if it's an induced coma or not. What's the difference? Thank you. Well, I can tell you what the difference is between an induced coma or not. An induced coma is when someone is induced into a coma with sedatives, such as propofol, midazolam/Versed, Precedex, and often also opiates such as morphine or fentanyl. Right? That's an induced coma. Now, given that your family member had a cardiac arrest and possibly had a brain injury here, can't be certain, but if it was 11 minutes of CPR, it all depends how effective CPR was, right? And if you're waiting for an MRI scan of the brain, well, get one done. I am wondering whether your family member is in the right facility here if they haven't had an MRI scan of the brain. The bottom line is, if your loved one is not on sedation and opiates, then it might be a natural coma. And then there's a high chance that your loved one is having a brain injury because they can't wake up. Shannon, this is live now, but I'm going to wrap this up in a minute because I usually go for an hour and I've only got a couple of minutes left, but I do these YouTube lives every weekend. I usually do them 10:30 a.m. on a Sunday, Sydney, Melbourne time, which is currently 7:30 p.m. Eastern Standard Time on a Saturday night in the US, which is 4:30 p.m. on a Saturday afternoon Pacific time. So I am actually going to wrap this up in a minute, Shannon. I do apologize, but like I said, I do these YouTube lives once a week, and you will get notification for the YouTube live if you are a subscriber to my YouTube channel, or if you are a subscriber to my email newsletter at intensivecarehotline.com. We'll announce it there as well. Now, with Intensive Care Hotline, we are having a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com. If you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email. And we answer all questions intensive care related. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. Now, and I also talk to doctors and nurses directly on your behalf, and I ask all the questions that you haven't even considered asking. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. Now, with intensive care at home, we are sending our critical care nurses into the home, and we're providing a genuine alternative for families in long-term intensive care patients. We're sending them home by providing a genuine alternative to a long-term stay in intensive care. We are employing hundreds of years of intensive care nursing experience combined in the community, and we're bringing a high skill level into the community with intensive care at home. And you can check out, or you can find out more information at intensivecareathome.com. We are currently operating all around Australia with intensive care at home, but we can also help you privately in the US or in the UK if you want to look into intensive care at home. With intensive care at home, we are NDIS approved all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, and IISQ in Queensland, as well as the DVA all around the country. We are also providing level 2 and level 3 NDIS support coordination for intensive care at home. Now, and if you like these videos, subscribe to my YouTube channel, give the video a like, share the video with your friends and families, comment below what you want to see next, what questions and insights you have. Like I said, I do these YouTube lives weekly. And Shannon, what I will do with your question, you're saying my husband is critically ill in the ICU now and the doctors and his sister are pressuring me to withdrawal of care, I think that means. I'm not sure what WLST stands for, but I will find out and I will make a video about it this week because I'm not having any time now. I do need to wrap this up. Thanks again for watching this. Thanks for your great attendance. And I will talk to you again next week and during the week with my quick tip videos. Take care for now.